Good afternoon, dear audience. Let me present my PhD topic titled Anemia During Pregnancy, Effects on the Offspring. I am Isabel Amorim. I'm a PhD student and dietitian. My vision is that pregnancy can have better outcomes through early detection of anemia and implementation of nutritional interventions. And my mission is to raise awareness among pregnant patients regarding the effects of anemia. These are my current ongoing projects. And I'm going to start by the first one, which is titled Investigating the Risk of Anemia on Pregnancy Outcomes. And I did this through a systematic review and meta-analysis. We know that anemia is quite prevalent worldwide, accounting for over 30% of prevalence in women of childbearing age. And approximately 37% of pregnant women are also anemic. It is a known risk factors for pregnancy outcomes, for example, low birth weight, and they increase the morbidity and mortality of both the baby and the mothers as well. Anemia in pregnancy is defined as hemoglobin lower than 11 grams per deciliter in the first and third trimesters and lower than 10.5 in the second trimester. And is also divided into degrees of severity, having mild, moderate, and severe types. A bit of these outcomes that can occur are preterm birth, which is defined as any live birth lower than the 37th week, and small for gestational age, which is defined as newborns with a birth weight lower than the 10th percentile for gestational age, and intrauterine growth restriction, which is the impoverished fetal growth and can have many causes and has quite a high prevalence from 8 to 10%. So our aim is to identify the associations between anemia and also the pregnancy outcomes. Our clinical question is whether anemia increases the frequency of these adverse pregnancy outcomes. So our population are the pregnant patients, our risk factor is anemia, and our outcomes of interest were preterm birth, spontaneous abortions, IUGR, small for gestational age, and perinatal death. Our hypothesis is that anemic pregnant patients have a greater odds of having adverse pregnancy outcomes. We conducted a systematic search made out of these three domains, so population, condition, pregnancy outcomes. We had quite a large number of citations that we narrowed down to 201 that were included in the systematic review part. So these are the results. We had adjusted and non-adjusted analysis coming from the original studies. I'm going to show the non-adjusted ones because there are too many plots. But these are the odds for preterm birth. So we had 1.49 higher chances of having a preterm birth in the anemic groups. The heterogeneity is quite high. It's ranging from 99% to 99%, so it's quite heterogeneous. Intrauterine growth restriction also showed an odds ratio of 1.15, but it was not statistically significant. And it was the same for small for gestational age, which we found an odds ratio of 1.23, but also not significant. However, when we were analyzing the degrees of severity, severe anemia was shown to be associated with most of these outcomes. So, and was also very significant in the sense that it caused 3.43 higher odds for these anemic pregnant patients to have a preterm birth and 2.48 times higher chances for IUGR babies. Also for accounting for the perinatal death and stillbirth, neonatal mortality, and also perinatal mortality, accounting for all these miscarriages, stillbirth, and neonatal mortalities, we had 3 times higher chances and almost 5 times higher chances for neonatal mortality. Our conclusion is that maternal anemia is associated with preterm birth, even when adjusted for confounders, and no significant associations were found between the morbidity and small for gestational age and intrauterine growth restriction. Severe anemia, however, was a known risk factor, is a risk factor for all the investigated outcomes, except small for gestational age. We have a few strengths and limitations. We would like to highlight our strengths that we was a comprehensive sample size with almost 20 million women included in one of the analyses, a few analyses. And also we conducted analysis of the poorly investigated adverse outcomes like IUGR that we do not find much in reviews. And also the limitations were the statistical models from the primary studies. They were highly heterogeneous between each other. The etiology of anemia that is not clearly described in most of the studies, and also the heterogeneity. Our application for practice is that ACOG, although it already recommends the screening for anemia during pregnancy, we should reinforce the counseling regarding birth spacing, lifestyle habits, supplementation, and nutrition education as well. The implication for research is that we should conduct more randomized controlled trials, now assessing the effect of treatments as well. So the most successful clinical approach in patients with inherited and non-inherited anemias. And also researchers should investigate the efficiency of iron supplementation, which dosage and time of and route of administration. This is our manuscript status. We submitted to IUGR after a very thorough review and very good recommendations. It was unfortunately rejected, but we're going to submit it again to Acta Scandinavica. And this is my second project, my second topic, which will yield 2 projects. So I'm going to discuss the first one, which is a systematic review and meta-analysis. And it's called investigating the impact of anemia on congenital anomalies. We know that congenital anomalies affect approximately 3 to 6% of the offspring worldwide, and they are divided into major and minor congenital anomalies. Unfortunately, these congenital anomalies they account for 240,000 newborns deaths before the 28th days. So every year this happens. We have a few prevention strategies, for example, prevention for STIs, management of chemicals, avoidance of embryotoxic medications intake, vaccination against rubella, and also fortification with micronutrients. We know for sure that micronutrients intake, when it's low, it leads to neurotube defects. And when we supplement with folate deficiency, the supplementation leads to better outcomes. However, the scientific literature still lacks clearer results on the impact of iron deficiency anemia during pregnancy. Our aim is to identify associations between iron deficiency anemia and congenital anomalies. Our clinical question is, does the gestational anemia increase the frequency of congenital anomalies? For that, we're going to assess the pregnant patients up to the first trimester. And we hypothesize that anemic pregnant patients have a greater risk of having major congenital anomalies when compared to the non-anemic ones. Our implication for research and practice is to decrease the frequency of major congenital anomalies by identifying patients at risk. This is our preliminary research. It yields over 6,000 citations, and we are going to submit to Prospero very soon. The second project is a registry analysis, which is in the same topic, and anemia with iron supplementation on congenital anomalies and pregnancy outcomes. So we have a registry here, very well known, that has yielded over 800 publications, which is the Hungarian Case Control Surveillance of Congenital Anomalies, and we're going to use this data set to answer 2 clinical questions. So we have over almost 90,000 pregnancies that were analyzed. The first question is whether pregnant patients in the first trimester exposed to anemia will have higher incidence of congenital anomalies, the structural ones. And we hypothesize that anemic pregnant patients have a greater risk of having major congenital anomalies when compared to the non-anemic. And our second clinical question is regarding the iron supplementation. So if iron supplementation decreases the frequency of congenital anomalies and pregnancy outcomes in the anemic population. For that, we're going to use the PICO framework, and we are going to use only the anemic pregnant patients in the first trimester that whether used or used not the iron supplementation and assess the outcomes of congenital anomalies. We hypothesize that anemic pregnant patients have a greater risk of having babies with congenital anomalies compared to the non-anemic. Our application for practice and research is to decrease the frequency of major congenital anomalies by giving optimal nutritional advice and treatment. In summary, these are the 3 ongoing projects. We plan to finish both of these last ones until the end of the year. Some additional activities were a few publications, so 1 first author publication, also co-authored 3 D1 publication with my co-investigators, and also a Q1 publication. Thesis work from my TDK student, and also the Semmelweis Symposium, and working as a SMS and lecturer here at CTM was a great pleasure. And let me finish my presentation with a quote: "Reserve your right to think, for even to think wrongly is better than not to think at all." Hypatia. Thank you for your attention.
Congratulations. My question is, then when you detect anemia, or in the meta-analysis, at what gestation age was detected?
It was heterogeneous among the studies. So some of them just reported as somewhere during pregnancy, and some other studies, they were very clear about which trimester they measure it. What we did was to use the ones that they measured during pregnancy, and to lower the heterogeneity of these measurements, we considered the third trimester's measurement of anemia when they reported per trimester.
Well, as concerned the Hungarian prenatal care guideline, we performed the screening for anemia at the first trimester. However, many pregnant join to the prenatal care after the first trimester, unfortunately. And doesn't matter at what gestation age you check the anemia, because as concerned the major congenital anomalies, it occurs in the first trimester. And the second thing, what is also doesn't matter, is the iron supplementation. Many pills contains iron and folic acid, and of course folic acid has a well-known effect against the neural tube defects. So I recommend to make difference between iron supplementation alone and iron supplementation combined with folic acid. Mm-hmm. Thank you.
Yeah, thank you very much. And we are going to do that whenever possible, because some of studies, they do not really report the type, but we have found some that have folate supplementation alone and folate supplemented, and with iron as well. So we can compare this way regarding the supplementation.
So you mentioned in your first project that you had a high heterogeneity of statistical models used in the article. Can you point me out what you particularly mean by that?
Yes, we had a high heterogeneity. It was, in the first plot especially, we had a 99% with the confidence interval varying from...
I think you mentioned in the limitations,
yes,
that there was the statistical models used in the individual studies were different.
Yeah, because they were, we used also adjusted analysis of the multivariable analysis that they reported, and some of them used, for example, just one more variable, for example, gestational, previous birth was the most common one, so parity as well, and some of the other studies, they included many covariables. So socioeconomic status, also supplementation, everything that you can have an impact on the outcomes that we assessed, they included in the models. But others didn't include much. So that's why we could not really have, how to say, so equal analysis for these studies.
Yes, but you have like finally 201
yes.
studies, right? So when you pull together adjusted values, right?
Yes.
And could you like make the pooling selective, or you pull together adjusted outcomes that are adjusted from the same predictors? Anything adjusted, pull together?
Yes, it was basically that. Because we didn't have many studies for each outcome. We had a lot of studies for preterm birth. So these 201 studies, half of them, mostly, they reported just preterm birth and not all of them. And then in the others, we have like 6, 7 studies included, but unfortunately, the adjustments were not very equal. And the first strategy was to come up with a multi-level model analysis, but in the end, we just analyzed normally without this model.
Okay. My second question, if I may ask it as well. You mentioned that more RCTs would be necessary. What would be your ideal RCT setup?
Well, if I had enough money for conducting an RCT, I would follow up these ladies prior to the pregnancy, so like 3 months before, to assess anemia, and also, well, give the supplementation even before the conception. And in the end, well, randomize these patients into a group that will receive iron supplementation and other group that will get just like folate supplementation, and then in the end of the 9 months assess the pregnancy outcomes that they had. But yeah, this would be regarding supplementation only.
Thank you for the answers.
Thank you.
My question, thank you very much for your lecture. the congenital anomalies. So how were these detected? How deep was the workup of these cases? And yeah, that is the first question, and let me just hear what you think about it.
Okay. Well, some of these births were just, the congenital anomalies were only assessed after the live birth, but others were assessed like in the first trimester and the second trimester with the ultrasound assessment in the case of the registries. And then in the systematic reviews, what we see is also just assessment via ultrasound during the gestation.
What kind of development abnormalities are we thinking about?
To assess?
Yes, what were the most prevalent?
The most prevalent
most
ones,
frequent structure abnormalities.
The most frequent ones are the congenital heart defects. Also in the registry, this is what we found. Also the musculoskeletal defects are the second most common ones. Cleft lip are also quite prevalent, but most of it are just the congenital heart defects and the musculoskeletal defects.
Skeletal, cardiac abnormalities.
Yeah.
Was there any genetic workup?
No, we are not going to assess the genetic ones, just the structural.
One question, I mean, anemia is not equal to anemia, right? I mean, I never understood medicine with cutoffs of, 10.9, you're okay, you're wrong, and 11.1, you're, healthy. So it doesn't make any sense to me. Were they somehow able to find some gradient, can you look at this deep anemia? Because obviously if somebody has anemia, there's a severe anemia is more likely to have, I would assume, these problems, but it's because the underlying disease they have,
Yeah, exactly.
and not the anemia.
Exactly. Yeah.
So how can you adjust for that?
This is the problem of the original studies as well, that most of these analysis of severe anemia, they occur in the Southeast Asia and also Sub-Saharan Africa. So the underlying causes would be malaria, for example, or other inflammatory diseases, and not only because they are iron deficient or anything else. But this was what we cannot just say, okay, if you supplement this people with severe anemia, even with intravenous, this is going to be corrected. No, because of the underlying causes. But what the original studies did was to come up with an eligibility criteria that we consider that this is okay enough to include. So we excluded primary studies that only analyze people that had, for example, a chronic disease or something that would hinder the analysis in the end. But the problem is that many studies do not report anything about the eligibility criteria. They just say, okay, we enrolled pregnant patients and we assessed the pregnancy outcomes. And here are the anemic patients. So this is the issue, and that's why we have high heterogeneity, and we cannot draw very robust conclusions because it's only as an association. It's not cause-effect. So that's the problem.
May I have a question regarding this? Maybe you could subgroup, or maybe you subgroup for quality of risk of bias.
Okay, yes, okay. We didn't do that, but it's a very good idea.
Because this is a very common problem that it's not just anemia is not equal to anemia, but study is not equal to study.
Yes.
And this is now a recent idea, getting more and more common in CTM, that we should do that to subgroup or subset for quality of studies, because simply the strength of evidence might very strongly depend on it.
Okay, thank you very much.
And you have enough patients for that, or enough studies?
Yes.
Then I have a little pet peeve across all. People say, adjust for a factor. You never adjust for a factor. You adjust for the effect of a factor. So it's very important, also when you write it, that you're never adjusting for the factor because you're not capturing it fully, right? But the effects it could have on that in that analysis. It's just a wording issue, but it's the same thing. It's multivariable, all those words mean something, and precision, even statistics, shows knowledge of what you're talking about.
Thank you.
Small details. But I guess it's like statistics, like everything else, the believers in this, believers in that, and it's like a science, like out of field, and the wording as well is taxonomy is very important. But I'm not a statistician.
The more you say you aren't, the more we suspect that you are.
Sorry, I think maybe you answered already, and I'm sorry for asking, but you mentioned that preterm births had a higher risk in anemic patients. Did you check for the socio-economic status of these pregnant women? So maybe it can be one cause that women who already don't take the supplementation because they can't afford it, so they would have preterm birth anyways, so more frequently.
Some of the studies they assess the socioeconomic status in their analysis, but not all of them. So unfortunately, we cannot answer this question, although it might be true because many of these studies are conducted in developing countries. So there might be an association, but I do not have the analysis to show you how much this is about in odds ratios.
So you try to first to publish it in IUGR, right?
Yeah.
I don't want to tear up wounds, but can you please share on what grounds did they reject?
Well, they mentioned, they were very respectful, and they pointed out things that we already knew that were wrong. They said that the point of a meta-analysis is to gather the studies that are comparable. And this is what we didn't do, because we compare everything. And they suggested that we should also analyze those studies that had, like, for example, complete blood count, or also analysis of ferritin to draw conclusions about iron deficiency and the outcomes. And so most of they just rejected because our meta-analysis were pulling everything together, basically, and not separating in subgroups, for example.
What did your statistician say to that?
He does not know about this rejection letter yet. I'm going to forward it to him and plan what we're going to do.
But it is like, because it sounds quite constructive,
Yeah.
I think, and also the ideas, the same questions come up. What can you pull together, what you can't pull together?
Yes.
So basically, there is still a chance to resubmit?
No, they unfortunately declined, and also proposed to transfer the submission to a Q2 journal. So this is what we're...
Very nice of them. Okay, thanks.
Thank you.
And Isabel, I also want to ask you concerning these 200 studies. So do you have enough just about iron deficiency anemia? I hope so in 200 pool.
We have a few studies, not more than 10. It's a very little number that they come up with all these examinations. It's not too much, unfortunately, because this was the primary idea. But we are going to subgroup these for sure.